Good morning. I'm Sarah. I'm a research coordinator at the Foundation. I'm presenting the Complexa pH study. It's a new study we're doing with Dr. Fenstead and Baxter. It's looking at a new medication called CXA-10. The study is to determine the efficacy and safety of it. And it's different from currently available pH therapies because it works by anti-inflammatory, antioxidant, anti-fibrotic pathways rather than inhibiting vasoconstriction or promoting vasodilation. So the study will be done primarily out of Baxter. Patients will travel to Minneapolis for some testing, but it'll be primarily Baxter patients. It's not for patients who are new pulmonary arterial hypertension patients. It's more for people who have an established diagnosis and are already on therapy. That would be an additional therapy. And then patients would be excluded if they have significant comorbidities or have recently been medically unstable or chronic AFib. So we are open to enrollment. So if you have patients who might meet this criteria, let Dr. Fenstead or I know, and we could try and see if they meet criteria for the trial.
Good morning, everyone. Thank you for coming, and it's my great pleasure to present our speaker today, Moses Wananu, who is our third-year cardiology co-chief fellow, originally from Kenya, who graduated from Ross University School of Medicine cum laude, and did his internal medicine residency and then additional chief year at Danbury Hospital, which is a Yale-affiliated hospital in Connecticut. Moses is very passionate about global health, and he actually led many medical missions, mission trips to Kenya, starting in his medical school. He actually played a big role in rebuilding cath lab in the East Africa's largest hospital, Kenyatta National Hospital. He does a lot of volunteer work locally, and also has published multiple manuscripts and case reports, and just a recent one, in fact, that I read about on Twitter. So Moses is moving into an electrophysiology fellowship at University Hospitals Case Western Medical Center starting this July. And he'll talk to us about different cases and clinical dilemmas.
Thank you. Hope you can hear me okay. I'll try to project as much as I can. So I'll give you cases here from the trip that I did. And I'd like to get some of the feedback from some people, just remove some of the resources that we have here, because this is the challenges that we faced when you're out there. And I'm curious, if you have only medications, how are some of the ways you could treat? And if you have limited surgery, what would be the timing of surgery and things like that? So that's Nairobi, the capital city of Kenya. But then Nairobi looks nice, but there's some pictures I'll also show you as we travel along the way, and also in Ethiopia. So the first case, we have a 21-year-old male. Just one second. Let me just change the presentation slide here. All right, 21-year-old male presenting with 1 week of fatigue. He played soccer but was stopping more often. And 1 month prior to this, he had pneumonia and was treated, unknown antibiotics, but he finished the course of antibiotics, felt somewhat better. And then he comes back. He had come to an outpatient clinic just because of night sweats and intermittent chills. He was not taking any medications at this time, and no other medical history, just somebody who was really healthy. This is the EKG. Any of the fellows? Yes. So this is the first EKG. We were on a different part of the hospital, then somebody comes running in and shows us this ECG and says, we have this 21-year-old who's just complaining of shortness of breath and fatigue, and this is the EKG. So we got curious. We grabbed echo. It's portable. I think it's the $15,000 one where it's hard grade. It's not the best quality, but you can get some images. So we took it, rushed to the office, and then this is the first shot of the first tunnel that we got. I realized we didn't have time to get it. And right away, you can see that there's something wrong right there. Left atrium, left ventricle, the aorta. Put some color on. It's hard to say there's still some perforation here, but definitely you can see there's AI. Still image there. This is the 4-chamber view. So here it's an incidental finding from just a clinic, somebody walking in and seemingly healthy with his dad. You see this and you start discussion about, okay, what are we going to do with this? So right away, this one more view. And I think when we put color on here, I think there is some suggestion of flow into it, which probably, I don't know if you call it an aneurysm or purely abscess. And it measured about 2 by 1 centimeter. So, treatment options. First thing we thought, well, we had a surgeon who was visiting from Texas. This was one of the mission hospitals. And he had just done 2 or 3 cases that day, but we were still going to go to his house because when you're there, everybody is closed. You don't have to worry about consult and paging somebody. Just really walk up to where they are and just knock on their door, show them the images, what's going on. So he got admitted to the ICU, hemodynamically stable. The vitals were okay. And then we started on broad spectrum antibiotics by infectious disease. And then did the surgery consult. We went and showed him the images. And I would have liked to hear what the surgeons here would have said, but he did not feel at that time that it would be good to go in because all that seemed like there was no place we'd be able to sew anything into because just the example he told us, it seems like it's sewing into tissue paper. But the other question was, what are you going to do if you have an abscess, just giving antibiotics? So continue antibiotics, pray and hope that he gets better. With these statistics, that 45% of people with that kind of abscess, they'll have in-hospital death and 58% one-year mortality if you only do medical treatment. But what are the surgical options? About 21% in hospital and 29% if early surgery is done. So the initial blood cultures that were obtained were negative. He remained afebrile. And by the next day when we saw him, we just told him that there's really nothing we can do at this point because the surgeon was, not willing to do anything. But I'm just wondering, in our case here, I think this is somebody who would have taken to surgery, right? Or any comments? So far, yeah.
He had no fever, but you presume this to be endocarditis.
Yes. Because of the recent infection, pneumonia, upper respiratory infection, and yes, yes.
And
the aortic insufficiency is also not helping because his diastolic time is forever, right? So, there's a lot of volume overload as well. But yeah, there's a 30-degree AV block. He probably has an aortic root abscess. It would be surgical indication.
So timing of surgery, according to ACC and ECS. So I'll cover a few of the class 1 indications for this. It's really three or four things: heart failure, uncontrolled infection, prevention of embolization, which is a kind of a vague term. And under the heart failure, the ACC guidelines, the 2014 ones, say early surgery for valve dysfunction causing heart failure. And the European Society of Cardiology says emergent surgery if you have refractory pulmonary edema or cardiogenic shock. And uncontrolled infection is if you have persistent infection after 5 to 7 days of antibiotics, which is kind of what the surgeon felt like. He was there for a month. They give him antibiotics for about 7 days, and afterwards see if it improves. If they have continuance of heart block, abscess, or resistant organisms. So I do think this patient already meets the criteria for surgery and should have gone to it. ECS says urgent surgery for the same thing, abscess or pseudoaneurysm or enlarging vegetation. And prevention of embolization, this gets a 2B. Some goes, according to the Europeans, if you have over 15 millimeters of vegetation length, but no class 1 indication. Neurologic complications, and I don't know if everybody does this, but it's one of the things that I've heard. I also don't know about what would be the appropriate timing of surgery if somebody has embolic phenomena and you do MRI and they have mitotic aneurysm, and yet, the blood cultures are negative. But possible imaging can be considered if there is a neurologic complication, and also they should go to surgery earlier than later. So this was a picture I took while I just showed you out of Nairobi and then on our way inland. Some of the places you go, especially at night, you gotta be careful because we're sharing roads with some of the cattle when we went in the rural areas. The second case, so I know a lot of this will be very unsettling. So the overall consensus was be on antibiotics, and then he was actually going to be discharged home because his dad said, well, you're not doing anything. I'm not going to be paying for him to stay here, and the surgeon won't take him. And therefore, the plan was just give him antibiotics for a week, then send him home, come back, repeat imaging. If it's improved or scarred, then consider surgery at that time. So this second case, I termed it, I don't believe that, because this was the attending that I'd gone with. He said he's never seen this, and I even said it the first time. And this is a 23-year-old male who came in for follow-up of shortness of breath. He has history of rheumatic heart disease. He was brought in by his brother, who happens to be a nurse, and he was diagnosed with rheumatic heart disease about 6 months prior, and had been scheduled to, for evaluation of valvuloplasty because it was severe. So he walked to the clinic, but he was really short of breath. Medications was on atenolol, just for heart rate control because he had severe mitral stenosis as well. Sildenafil, 20 milligrams TID, and furosemide, 40 milligrams PID. He had taken those medications earlier that morning. So physical exam, I think this tells it all. And by the way, all these patients have given me their consent, take pictures and everything. So that's a look. While just listening to him, you can see his tripoding is barely, taking deep breaths, and it was just deteriorating by the minute. This is the first echo. very severe calcified mitral valve. Not a lot of MR. Again, pardon, these images might not be the best, but there was also TR. So nothing to say, can't believe that so far. Except when we start getting to this, and then eventually we're able to put a Doppler across the, so this is another view. You can see the LV is really encroached by the pressures on the right side, and it's almost collapsing there, the left ventricle. And so the first pressures, before I told them to do this, they said they did the tricuspid valve Vmax. No, the peak, the gradient that they got was 174. So of course the first thing I said, no, I don't believe that. I haven't even heard such numbers. So I told Dr. Johansson, and he said, there's no way it's 174. I don't think they've measured it correctly. So I told them to measure it again. And this is one of the measurements. You can see 164. And then the next one, about the same, 164. And there's probably a better one here to measure the mitral valve gradient, but roughly it comes to 28 to 30. Taking 3 to 4 measurements was anywhere from 25 to 30, which is really high. So the question is, you have this guy who is deteriorating right now. When we put him on the side to try to get IVC, we had to stop because after a minute or so, he was so uncomfortable that he just getting up the IVC, few shot was just really dilated. Therefore, the first thing we said, we'll admit him right away, rushed him to the ED to get him admitted. And the question here, I think for the audience, I wonder, what would you do as you're waiting for, probably, would you do emergent valvuloplasty in this case, which we thought about? But I'm curious to hear what people would think about in somebody who is so decompensated at this time. And are there any medication options that you can do to temporize them while they're getting there? Yeah, but at the time, actually, we did not have the setup. The C-arm had broken, so we could not do valvuloplasty at the time. But we just kept thinking probably this would have been a great patient for valvuloplasty. But in the meantime, as they're just to getting them there, the choice was you on Lasix because now in a short time started having frothy sputum coming out. So he had been put on by, I think it was a different physician that he was seeing. And apparently on sildenafil, he reportedly felt better. And in fact, one of the things he was saying, since he had not taken the medication, it had been almost 10 hours since he took it and was able to walk in. The nurse, asked us, is it that he did not take his medications? And that's why he's not feeling great. Although in this case, I would think it's almost contraindicated to give it at this time. Yeah. Couldn't. Okay.
And I think at least that would, I think that would give you at least some sort of an, indication how high his wedge is, and then you would know whether giving him sildenafil, that is a pretty impressive RV.
Yeah.
So, the question is there any superimposed primary arterial hypertension,
yes.
On the just the plain old, MS?
Yeah.
So that, I think, would be very helpful to do that. And I also think just doing non-invasive hemodynamics with the echo would really help you get, VTI and get a cardiac output.
The heart surgeon is there. So he was still there, but I think even at this time when you had called, he was in a case. So would you give furosemide? Because now his lungs are getting really crackled up. Because the other fear is that if you drop his pressures, the systemic pressure, then you lose him. But here we are taking him to the ED, telling you're admitting him, but the question is, what should we give him? Really, there's really no options. So there was a thought of maybe give Lasix, but the difficulty you ask them to give Lasix. This is rural, really interior, so the family has to go buy it in the pharmacy, and bring it. So anyway, in the meantime, we told them you have a very sick person here. Think of admitting him while we talk to the surgeon. As soon as he finishes the case, maybe he can come and see this guy. There was mild delay in starting any medications, because then it was like, well, I'll just grab my sildenafil, which I've been taking and feeling better. But while seated there in the ED, just started coughing, bringing blood, and just coded. And as soon as he coded, we knew there's no way of getting it back once the systemic pressures were low. So he just grabbed an echo and just called. But it was really unsettling. And I didn't include in this slide, but rheumatic heart disease right now is close to malaria in killing people under 40. It's one of the most common, cause of death for young individuals. Yeah.
He had this diagnosis of rheumatic heart disease before. What was it? Did you get any knowledge about the discussion?
What's that?
Was there any discussion beforehand? What was the time course for surgery and things like that? Because this is not he presents acutely, but rheumatic heart disease is obviously a chronic process.
Yeah. So he was coming in for evaluation of valvoplasty. But this time when you were there, the CM had broken, but he was coming in so that it would be done. So this was known, but these pressures had not been recorded before, and it was just a 6-month delay, and he had come from some long distance and done well, but just happened that he arrived at that time. Yeah. So for treatment in people, especially with severe and symptomatic that we already know with favorable valve morphology, Wilkins criteria, then they can get balloon, or on the other hand, they can get surgery. Let me just go to the next case. But from these two cases, I think the theme that was starting to catch on quickly was that people either came with late presentation of the illness, or there's complication of very limited resources. And the disease burden is just too high for any hospital. And we had so many deaths of very young people, and Amit, I know you'll be going there, and that's one of the things that was really unsettling to me, because you're seeing people that you're talking to, but you probably not see them the next day. It was a very common thing that we kept seeing, especially in these smaller hospitals. So you stretched out to the limit, and unfortunately, a lot don't get the care they desperately need at that time. And even if they come when people can do something, the line is way, way too long to do anything meaningful. So I caught this picture while passing in Ethiopia, and said the disease burden is much, and there's a lot of burden, even the horses feel it. I couldn't believe how high they were able to stack this, looking at the back of that of the donkey. So the third case, this is the first successfully treated case in East Africa. There was a surgeon from Texas, children's surgeon who now lives in Kenya and has been training general surgeons to do pediatric surgery. So I got involved with this case because I needed somebody who can do TEEs, and I was there. So it's a 7-year-old boy with distended abdomen and pain for a few months. He appeared small for his age, and he also seemed to have Down syndrome. On auscultation, I have never heard of pop sound, but here is the first time I actually did. And this is the imaging. Anybody care to interpret it? The thing that jumps out the most?
The IVC is quite dilated for
Yeah.
some of these cuts.
Yeah.
Yeah.
All the way
Good.
up. And then the next shot.
Okay. Yeah. Mass in the right atrium there too.
Yeah. So it's coming all the way from the IVC going up to the left atrium, and there's also something else here. It's supposed to be kidney. Starting from there, going to the IVC, and all the way to the right atrium. Okay. So initially, I didn't even know if I can do a TEE because I was asking for, is there like a pediatric probe? They're like, no. So I asked the surgeon who does all these cases, and just felt the kid and told me, no, you can use the adult, it should go in fine. So I told him to put it, and this is the first few shots we got. And the reason they wanted somebody to do TE is because they wanted to do surgery and not open the chest, and therefore they would remove the mass and then try to encroach on the IVC and slowly pull it down. Because from just this first shot, I think you can also appreciate that there's a connection, there's a hole here going to the other side. And therefore the fear was, can they even be put under general anesthesia and go to bypass? So my work was to keep an eye on that, whatever mass that was, and just tell them if it goes to, if anything breaks off and goes to the other side. So thank you.
Tumor in diaspora. You were hearing this tumor, did you say?
Yes.
Because usually with the myxomas, as I recall, the plop is when it prolapses across the valve. And this does not look like it's actually...
It actually does.
It does? Okay.
Yeah, it does. Yeah. So I tried to follow it up to see how far it was going and if there was any attachment point. You can see as I was going back, it's just around the IVC, and I think put some color and told them at least there was some flow around it. And then eventually they were able to pull it, but at some point we had the vital sign go down because when they would pull it down and lose a little bit of the traction, it would come back and hit the, I think it was just hitting probably by the conduction system. And at some point we went to complete, transient complete heart block. Blood pressure dropped. Therefore they were able to be more careful and pulled it, and we hope everything was pulled out. I didn't see anything at least go across, but we were going to figure out the next day with a physical exam. This is it. Yeah. The surgery went well. It's a Wilms tumor. And causes of masses in the IVC to RA. I think the other ones we've seen is thrombus that we are concerned about, but going all the way from the kidney, it's really Wilms tumor. And then some other intra-abdominal malignancies can do that. At least this is what I read about. And our patient had nephroblastoma, which is 1 to 4% patients with Wilms tumor. It can actually travel all the way to the heart in pediatrics. There are multiple case reports regarding that. So this was one of the places we stopped over for lunch. Case 4, I called it Happy Mother. 25-year-old female with history of rheumatic heart disease, severe mitral valve stenosis, and severe regurgitation. Had heart failure before and had a prosthetic mitral valve done because she really wanted to have children.
The patient, oh, sorry. So the patient has endocardial cushion defect. So did that just be something to deal with? Never,
that's something to deal with later. Yes, yes.
That I think that's going to be an issue in a few years as well. I mean, that looks pretty promising.
Yeah. So fortunately, that they can fix with at the same hospital, and it was going to be followed later. And he was doing great actually the next day. He did not have any abnormalities. So this is a 25-year-old had prosthetic valve done so that they can have children, and had successful delivery 1 year out, and was just coming in for a regular checkup. She denied any significant symptoms. She said she's doing great. She's able to take care of her son, and that's her. Get an echo follow-up. That's what we see. Just see the valve rocking there. Put some color on. So this, she did not have any illnesses before, not denied any infection. We got some blood cultures there, but no symptoms at all. But she has this. And I think that's a still frame just to see it where the valve was placed before. So the question we had is, it's also very difficult to discuss with them that, yes, you're feeling great, but your valve is not doing well. But I think I was also shocked that the valve can degenerate that fast within a year and a half after the surgery. No, 2 years by that time. I'm not sure, is that common based on your experiences here and the few that you've seen?
About prosthetic mitral valves, there's a nice case series from California, the group from Stanford, I think you had published New England a couple of years ago. And biprosthetic mitral valve degenerate really fast.
Okay.
And that brings the concern about whether some of this patient, she was 30, right, 20-something.
24, yeah.
Yeah, she wanted to have kids, so that was the right decision. But, the surveillance is really key. So how long ago was the valve surgery then?
Barely 2 years.
The question is whether she had some, other repeated infections and or any cytos and things like that might have led to this degeneration so early, but that's quite early.
Yeah. So one of the questions I had, I know that, with people with rheumatic heart disease and they keep getting sore throat and things like that, since that tissue that gets destroyed by the M protein that we see that mimics the valve, after you put in a prosthetic valve, could that be the mechanism as to which there's still some of that tissue there and causing degeneration? I really don't know. I had no explanation as to why this fast, and all along she said she's been healthy. But in any case, she was hemodynamically stable. Told her to come back for surgery in 2 months to get a mechanical valve. Was to be started on furosemide, although I didn't see the real indication because she was not in heart failure at that time. And no further pregnancy. This is easier said than done because sometimes you do that You put them on warfarin and they come back pregnant, or sometimes just hear about them that you call at the hospital goes to deliver. So the last case I have here is a 50-year-old male. We're just called to the ED to interpret a chest X-ray. That looked funny. I'd never seen an X-ray like that. But when we were there, they said, well, come and tell us what you think this is. So it came in because of productive cough, 2 weeks duration, night sweats, minimal apnea, but no signs of heart failure at all. Had been taking over-the-counter medications without significant relief, and that's the chest X-ray. Anybody interpret it? Yep. So you have that tuberculosis. Then you have. Yeah. So this was a pulmonary artery, and so yes, getting admitted for this, but this also caught our attention. And quick view here. So I don't have the measurements here, but actually measured 7.4 centimeters. And here is about 2.5 centimeters. So incidental finding of pulmonary aneurysm 7.4, and we did not know. And I think I was talking to Dr. Olangi, how do you treat this? I tried to search for guidelines on how do you even follow them, what's the statement about them, but anyway, using a CT to define this, the main pulmonary artery should be about 3 centimeters and the interlobar about 1.7. Therefore, diameter of over 4 is considered pulmonary aneurysm. Anything greater than this, maybe it's an ectasia. Causes, there are many that are listed. You have congenital heart disease, pulmonary hypertension, and then you have acquired. Infections like TB can cause pulmonary, aneurysms, pathogenic bacteria, vasculitis, chronic PEs, really anything that raises pulmonary pressures. So the treatment is, there's really no clear treatment that have been defined. But there's a consensus statement I kept reading from, the experts. For the most part, it's conservative approach, and people can go extremes. There's really few things where people consider surgery. And the first one is if somebody has pulmonary hypertension with the aneurysm, that seems to be the most common cited reason as to why to do surgery. But from the AHACC also, they say that they'll just use the left-sided diameters, whereas if it's over 5.5 centimeters or increases with over 5 millimeter size in 6 months, especially with valvular pathology or shunt flow or verification of pulmonary arterial hypertension. In other words, anything that will make this keep growing, or compression of adjacent structures. The case reports of the left main that can be compressed, left recurrent laryngeal nerve, and also you can have like one of the interlobar tracheobronchial trees compressed, and somebody can have recurrent infections or some shortness of breath. But even for ischemia, if they have left main compression and ischemia, it's really hard because most of these people, if they have pulmonary hypertension and they're having symptoms of shortness of breath or generalized diffuse chest pain, might be hard, and there's some of them who just show up after sudden cardiac death. If there is thrombus formation in the aneurysm sac or clinical symptoms, then can consider surgery. And I know in some places they say if you don't have pulmonary hypertension, it's 6 centimeters, just watch it. But the reality is about 19% of them can have dissection without having pulmonary hypertension. And only about, I think, said 15% of them are usually diagnosed early. So that was the end of my presentation. And just a final thing, reflection I had when I went back for this international trips. This Erin Meyer has done a great job with communications and talking about the different cultures in the world and how they communicate, from feedback and just how we say things. And you can test yourself which part of the world you are. For example, United States has the lowest low context in the world because of multicultural. Therefore, if somebody says something, they mean exactly that. The far east you go, it's a very high context language where you have to read the air, like, Japan. You might give a talk like this and ask for questions, and nobody raises their hand, but there are a ton of questions in the room, and the way to know is somebody hits an eye contact with you, it means they have a question. Therefore, you point on them, they say, oh yeah, thank you for allowing me to ask a question. So, and then other things like direct feedback. When you're in Minnesota, you might be doing a very terrible job, but they'll never tell you directly. They'll cushion it with a sandwich, tell you, you probably could maybe improve on this area, but overall you're doing great. If you tell somebody from Germany or those countries that, they interpret that you're doing well. But if somebody from Germany or those countries, something is not done well, they'll tell you directly. And you say that to people in this area, they'll think you're mean, you're really bad. But it's a fascinating talk. And the reason I say this, if you go to international places and somebody is dying, it's a process. I remember rounding in the ICU and there was somebody who had fixed pupils on a ventilator, and I told the attending, that person is dead. Can you tell the family? And I'd forgotten how much I've lived here. So the green is me, that I'd moved away, getting more to the low context. Indirect negative feedback, I'd moved all the way to direct. But I'm coming from a country where some things can be indirect, direct. Way of bleeding, very hierarchical there. I've moved quite a bit, egalitarian. You can see consensual on deciding things. I've moved away from where sometimes top down to where it's mutual, shared decision. So it's very interesting when you do this and see where you lie, and when you're traveling, going to a different country, just to know where do they lie in the street. Because for those patients, they told me you have to wait. Let the family see the patient really, really doing bad. Then tell them the patient is doing not so good. We don't think they're going to make it, and they're already dead at that time. And then later on, but they'll still tell them that day. But it's a process. But for me, it was really hard to understand. Like, they need to pull them out of the ventilator and keep going. And then some patients I've seen here too, if you're trying to get information from them, if they come from international places, they might seem reserved and think, oh man, they poor historian, they're not saying anything. But maybe you need to draw a lot of things out of it. And the way you draw it is different than one might be. They might think, oh, that doctor is really brash. He just came in, told me what I need to do, and then they left. But really, that's not who you are. It's just, so it's fascinating if you can read about Erin Meyer. Thank you.
Questions? We've got the overhead mics on now, so I don't need to turn around.
Moses, just to educate me, how many hospitals in Kenya can do cardiac surgery?
So the main hospitals in Nairobi can, in Mombasa, and about 4 major cities can do cardiac surgeries. They do a lot. And then the physicians themselves, the cardiac surgeons, over the years they learned to do more than what they do. I had a cardiac surgeon from the former hospital. We went there. They did surgery on an adult patient turned out great. In fact, they said he's really talented. And then the next day, I asked him, so you're going to join tomorrow? I asked him, what for? I told him I'm doing a pediatric case. He said, no. And then he told him, what about Friday? I asked him, so what are you doing on Friday? He said, I'm doing kidney transplant. And, you know, friends like, what do you mean, how many kidney transplants have you done? It turns out he does one every 2 weeks. So he's kept up with that, but I don't know the level of training yet to do. I think he went to Israel additional years. So they do it, but the issue sometimes I have is some are not purely dedicated to that. They're also doing a lot of other things.